Welcome to this explainer. We're jumping right in today, taking a really deep, high-resolution look at the complex world of ocular pathologies. We're going on a layer-by-layer anatomical journey. We're going to start from the absolute outermost structures of the eye and work our way all the way back to the deep layers of the retina. So get ready because we're going to visualize these conditions like never before. To do this, we'll essentially mimic a precise clinical workflow. First, we'll look at the conjunctival response, then dive into degenerations and fluid shifts. From there, we'll examine cornea and eyelid architecture, and finally, wrap things up with posterior segment pathologies. All right, let's kick things off with Section 1, the conjunctival response. So, when you're at the slit lamp looking at the palpebral conjunctiva, your absolute first crucial task is differentiating a papilla from a follicle. It's all about the structural differences here. A papilla is fundamentally a vascular-driven response. It's got this central red vascular core, and that ties it directly to allergic or bacterial origins. A follicle, on the other hand, is a true lymphoid nodule. It's actually avascular right in the center, which pushes the blood vessels out to the periphery. And that peripheral vascular pattern, that's your classic indicator of a viral or chlamydial pathogen. Now let's zoom in on papillae for a second. Microscopically, we're talking about an inflammatory response defined by a central core vessel that comes right up to the tissue surface. Surrounding that dilated capillary, you'll find localized edema and a really dense infiltration of round cells, lymphocytes, plasma cells, and eosinophils. This is the exact mechanism you're seeing when you diagnose things like vernal and atopic keratoconjunctivitis, or even contact lens-induced giant papillary conjunctivitis. If we trace how this actually progresses, the early stage kicks off with a histamine release, causing those core vessels to dilate. Clinically, this looks like a velvety, hyperemic tuft of micropapillae. As it pushes into the intermediate stage, those capillaries start leaking protein-rich fluid, which actively stretches the conjunctival anchoring septa. Finally, in the advanced stage, those septa literally rupture under the mechanical or allergic stress. The papillae merge, exceeding 1 millimeter in size, and bam, you get that unmistakable, massive cobblestone appearance. And it's that heavy mucus production and physical friction that can ultimately cause those sight-threatening shield ulcers on the cornea. Shifting gears over to follicles, we're looking at a totally different mechanism. A follicle is an avascular, focal lymphoid hypoplasia. Basically, it mimics a tiny, localized lymph node sitting right there in the conjunctival stroma. It even has a germinal center completely packed with immature lymphocytes. And because that center is so densely packed with immune cells, the blood vessels have nowhere else to go but around the outside, wrapping the base of the nodule like a basket. The clinical progression here is incredibly vivid. It starts with an infiltration stage where T and B lymphocytes migrate into the tissue. This naturally leads to the maturation stage. When you're looking for these clinically, you'll spot them as translucent, round elevations, mostly in the inferior fornix. Honestly, they look exactly like tiny grains of rice. Now, in most viral cases, these will just resolve on their own. But in chronic conditions like trachoma, the follicular inflammation actually causes necrotic changes in those germinal centers, leaving behind permanent little scars that we know as Herbert's pits. Okay, moving right along to Section 2, degenerations and fluid shifts. First up in this section, we have concretions. Historically, these were called lithiasis, which kind of implies they're made of calcium. Let's just debunk that myth right now. Concretions are actually small, hard, yellow-white deposits of inspiciated cellular debris, keratin, and mucin. There's little to no calcium in there at all. Really, they're just the result of chronic, low-grade inflammation on the ocular surface. Tracking how they actually form, it's a three-step process, starting with entrapment. Chronic inflammation basically forces a downgrowth of the conjunctival epithelium, which creates these little inclusion cysts. Next up is inspissation. The cellular debris and mucus fill up the cysts, the fluid gets reabsorbed, and it all condenses into a really distinct, solid nodule. Finally, you get erosion. The overlying epithelium atrophies, and that hard nodule literally pokes right through to the surface. And that is the exact moment your patient comes in complaining of a sharp, mechanical foreign body sensation every single time they blink. Now, on the complete opposite end of the fluid spectrum, we have chemosis. This is severe edema specifically of the bulbar conjunctiva. Because this particular tissue is so loosely adherent to the underlying tendon's capsule, fluid can pool incredibly fast. We're talking sometimes in mere minutes. It just rapidly accumulates within the substantia propria. This is a classic hallmark of hyperacute type I hypersensitivity reactions like anaphylaxis or really severe orbital inflammation. The fluid shift we see here is honestly dramatic. It kicks off with vascular hyperpermeability triggered by mast cell degranulation. That immediate vasodilation leads right into fluid transudation. The plasma leaks into the connective tissue, and the conjunctiva just balloons outward. In really severe cases, it looks exactly like a clear blister protruding completely past the eyelid margins. And if that prolapse is exposed to the air for too long, it dries out, leading to desiccation and peripheral corneal Dellin formation simply because the tear film breaks down. Let's move deeper into the eye with Section 3, Cornea and Eyelid Architecture. The absolutely foundational concept we need to talk about here is detergence, the active, energy-requiring state of keeping the cornea clear and dehydrated. So corneal edema happens when those active detergence mechanisms, namely the endothelial pump or the epithelial barrier, become overwhelmed and just fail. This is a critical, sight-threatening finding when you're dealing with conditions like acute angle closure glaucoma or Fuchs endothelial corneal dystrophy. Visually, this fluid accumulation is very deeply layered. It starts down in the stroma. Once the stromal thickness swells by more than 10%, Descemet's membrane actually begins to fold in on itself, creating striate keratopathy. If the condition decompensates even further, the fluid pushes anteriorly, right into the epithelium. That's what creates that classic steamy or hazy-looking cornea packed with microcysts. The absolute end stage here is bullous keratopathy, where subepithelial fluid coalesces into large fluid-filled bullae. When those bullae finally rupture, they expose raw corneal nerves. It causes agonizing pain and immediately opens the door for bacterial keratitis. While all that is happening, chronic environmental exposure, like UV radiation and long-term inflammation, drives this destructive architectural remodeling of the eyelids and conjunctiva. You'll see elastotic degeneration, which, by the way, is exactly how a fibrovascular pterygium manages to aggressively invade Bowman's layer. Looking at the lid margins, chronic inflammation causes epithelial hyperkeratinization, effectively capping the meibomian glands with hardened lipids. You'll also likely spot telangiectatic neovascularization hugging the gray line. Eventually, the structural integrity fails, and the mucocutaneous junction physically shifts. This warps the lid into entropion, ectropion, or trichiasis, where misdirected lashes are just constantly scraping across the cornea. Moving inside the anterior chamber now, we encounter synechia. This is an abnormal adhesion of the iris to nearby ocular structures. It's almost always driven by anterior uveitis. What happens is the blood-aqueous barrier breaks down, pouring sticky inflammatory fibrin, proteins, and cellular debris right into the anterior chamber. This organized fibrovascular membrane turns the normally highly mobile iris sluggish and incredibly adhesive. Notice the distinct physical mechanics at play between these two specific conditions. In a posterior synechia, the back of the iris sticks tight to the anterior lens capsule. If this adhesion seals a full 360 degrees around the pupil, aqueous fluid gets trapped behind the iris, bowing it forward into this dramatic iris Bombay configuration. Conversely, anterior synechia, or PAS, is when the peripheral iris gets actively pulled forward and sticks to the trabecular meshwork or cornea. But whether it's bowing forward from behind or being pulled forward from the front, both of these mechanisms physically occlude the drainage angle, and that leads to devastating, irreversible secondary glaucoma. And finally, we arrive at our last destination, Section 4, Posterior Segment Pathologies. We have to start with the microaneurysm. This is the absolute earliest clinically visible sign of diabetic retinopathy. It all starts at a microscopic level with the loss of intramural pericytes, which usually provide the capillary walls with structural support. Without them, the capillary wall weakens and just bulges outward under normal vascular pressure. Endothelial cells then proliferate inside this little pouch, creating a hyperpermeable microvascular knot. When we look at the fundus, we see these as tiny, distinct pinpoint red dots. This is a great example of how retinal anatomy perfectly dictates clinical appearance. If a vessel bleeds into the superficial nerve fiber layer, the blood is physically forced to follow the horizontal architecture of the unmyelinated axons. That creates a striated, flame-shaped hemorrhage. But if that blood leaks deeper, say into the internuclear or outer plexiform layers, it gets vertically compressed by the Mueller cells. That forces the blood into tight, round dot and block configurations. And if it bleeds between the retina and the posterior hyaloid face, well, gravity just takes over. It forms a massive boat-shaped subhyaloid hemorrhage with a straight fluid line, which causes profound, immediate vision loss for the patient. Shifting our focus right into the macula, we absolutely must discuss drusen. These are extracellular deposits made of lipids, proteins, and cellular debris.
The key here is that they accumulate silently in a very specific, incredibly narrow anatomical space, directly between the basal lamina of the retinal pigment epithelium, the RPE, and the inner layer of Bruch's membrane. This precise accumulation is the primary driver behind age-related macular degeneration.
Let's trace the staging sequence of AMD. It starts with a silent metabolic dysfunction where those basal deposits just fail to clear. This isolated focal failure results in hard drusen, discrete, tiny yellow spots smaller than 63 micrometers. But as the disease worsens, these deposits grow and they coalesce into soft drusen, expanding beyond 125 micrometers. These large deposits literally start to choke the tissue, physically separating the RPE from its choriocapillaris blood supply. The resulting chronic hypoxia is a massive structural failure. It inevitably triggers either geographic atrophy, causing complete cell death, or neovascularization in wet AMD. As we wrap up this explainer, we can really see how all these pieces fit together. From the velvety micropapillae of the palpebral conjunctiva to the hypoxic, choking cell death deep in the macula, ocular pathology is truly a masterclass in structural failure. The exact clinical layers perfectly dictate the visual disease you see in front of you. So, the question I want to leave you with today is this. How will mastering these incredibly specific microscopic details and exact anatomical locations completely reshape the precision of your very next slit lamp exam?